This segment is on diagnostic tests and procedures related to the genitourinary system. As we start thinking about some of the diagnostic tests, the first one I want to think about is a clean catch urine. When patients are suspected of having a urinary tract infection, then a clean catch urine is obtained. May I assume that you all know how to obtain that? That means it's a midstream collection, and of course you have to cleanse the area. With the woman, you cleanse each side with an antiseptic wipe and then down the middle, and the man you clean around the meatus. Two blood tests are very important for us to remember. BUN, or blood urea nitrogen, is normally 10 to 20 milligrams per deciliter. An elevated level suggests kidney damage. Serum creatinine is normally 0 to 1 milligrams per deciliter. Normally, the kidney removes the creatinine from the bloodstream, so there's almost none in the bloodstream. The serum creatinine has a distinction of being affected only by kidney damage. So if the patient has an elevated serum creatinine, you know they have kidney damage. Liver damage can affect a BUN, but nothing else affects the serum creatinine. So that's sort of its claim to fame, if you will. Now we also need to think about an intravenous pyelogram, or IVP. This is an X-ray of the kidney. The dye is an iodine dye, so you may need to ask the iodine question of the patient: are you allergic to shellfish? And while allergic reactions, I won't say are common, they're not rare in patients who've had an IVP. So this is one where that allergy iodine question frequently comes up. Another test we might want to think about is a cystoscopy. Cysto refers to bladder. Oscopy means a scope goes into a body cavity. So a scope goes in and looks at the bladder. This is usually done under a local anesthesia. If so, then we oftentimes will have the patient drink plenty of fluids before the procedure. If on the rare case that it was done under a general anesthesia, then of course the patient would need to be NPO. A small amount of blood-tinged or tea-colored urine following the procedure is relatively normal and nothing to be alarmed about. If, however, your patient has bright red urine or clots in the urine, this is something you should notify the physician about. Want us to think also about catheterization, urinary catheterization. There are some questions that we know have been asked on NCLEX regarding this. There's been a question asked about if you were catheterizing a male, at what angle should you hold the penis? The answer to that is 90-degree angle, or right angles to the patient's body for the catheterization procedure. They might ask on the female, where is the location of the urethra, the urethral meatus, and the location is between the clitoris and the vagina. Now, when you're doing this procedure in the hospital, it really should be a sterile procedure. Now, there are a couple other questions that might relate to this that have been asked. One might be about obtaining a specimen for culture when the patient has an indwelling urinary catheter. And by the way, on the exam, it will be an indwelling urinary catheter. It's not going to be a Foley catheter, because NCLEX does not like to use trade names. So it will be an indwelling urinary catheter. So back to our issue here. If you need to get a specimen for culture and they have an indwelling urinary catheter, the first thing you need to do is clamp the tubing. And you might want to clamp the tubing down here so that it's really distal here, down in here, so there's enough urine that's backed up so you've got some here when you aspirate. If the patient has a sampling port, as in this catheter, then you clamp their tubing, not long, 5-10 minutes, plenty of time. You clamp their tubing, then you cleanse with an antiseptic wipe, you cleanse the sampling port, and then you put your sterile needle in and aspirate the urine from there, put it into the culture container, and send it to the lab. However, if the patient does not have a sampling port, you would need to get this urine, you need to go directly through the catheter. So that means that you would have to cleanse the catheter distal to the bifurcation. Now, bifurcation means branching. So where this little part goes off. Now remember, this is the part that blows up the balloon that's inside the bladder. So you must make sure that you put that needle in distal to that. If you put the needle in up here, you could easily puncture that little tube that goes up there and deflate the balloon. So we need to cleanse and aspirate distal to the bifurcation. So that's how we get a specimen for culture in a patient who has an indwelling urinary catheter. They could also ask you questions about positioning of the catheter, especially in a male patient. So when we look at this, we know that if they're going to have the catheter in, particularly for any length of time at all, it's best to put it either lateral to the side or even up to the abdomen, but not hanging down. And the reason that we don't want to put it down is that right over here at this area called the penoscrotal junction, right in there, if you have that catheter just constantly rubbing in there, that can create irritation and damage to the urethra. So I'm willing to bet you've seen it wrong in a lot of men, and sometimes we get away with it. But the better way is to put it either lateral to the thigh or even up to the abdomen. Now I want to take a moment and talk about what the kidney does. And I'm doing this really to kind of prepare us to talk a little bit about dialysis. So what happens when the kidney isn't working? So let's take a look at the picture here. This is kind of a schematic drawing. This part in here is actually convoluted tubules, and I just don't draw convoluted tubules very well. So here's our glomerulus up here. Now, with the convoluted tubules, remember we've got blood vessels that go around and around and around and around in here, and things move back and forth until finally what happens is we get urine, drops of urine formed. Now all of this stuff here has been removed from the bloodstream. So everything that's in your urine has actually been pulled out of your bloodstream as it flows through the kidney. So the kidney is supposed to remove the hydrogen ion. If the kidney does not remove the hydrogen ion, the patient will go into metabolic acidosis if that stays in the bloodstream. The kidney is supposed to remove ammonia, and ammonia is supposed to be in your urine. If it is not removed, the patient develops high ammonia levels and high BUN levels. High ammonia levels make the patient very confused. The kidneys are supposed to remove potassium from the bloodstream. If the kidney does not do that, then the patient develops hyperkalemia. The kidneys are supposed to remove creatinine from the bloodstream and put it out in the urine. If not, the serum creatinine is elevated. Likewise, the kidneys pull phosphorus out of the bloodstream and put it into the urine. If they can't do that, the phosphorus goes up. And remember, every time your phosphorus goes up, your calcium goes down, which is why we have to give calcium and vitamin D supplements to patients who have kidney failure. The vitamin D is for the absorption of calcium. The kidney is supposed to pull water out of the bloodstream, and that's what makes the fluid the liquid part of your urine. If the kidney can't do that, then the patient has fluid retention and edema. So these are the things that happen if the kidney is in failure and can no longer do the things that it is supposed to do. These are what I call the filtering functions, if you will, of the kidney. The kidney also has another function. It has a manufacturing function. And the manufacturing part of the kidney is that it produces something called erythropoietin, abbreviated in this little picture here as EP, erythropoietin. Now, erythropoietin is necessary to make red cells, and red cells, of course, are necessary to carry oxygen to the rest of the body. So normally the kidneys produce erythropoietin. A patient in renal failure has less erythropoietin, and that means that they have fewer red cells. So most patients in renal failure are anemic. Now, we will be talking in just a moment about dialysis. And I want you to remember that dialysis helps all that filtering part that we talked about a moment ago. Dialysis does not help the manufacturing part of the kidney. To help the patient have more red cells and stimulate red cell production, we usually give them something called erythropoietin or epigen. There are some forms of that available, and we usually give that to these patients. Now I want us to look at dialysis. The functions of dialysis are to, one, remove end products of protein metabolism from blood, two, to maintain safe levels of electrolytes, three, correct acidosis, and four, to remove excess fluid. This is essentially that filtering function of blood that we were talking about. Now, if you think about how the kidneys normally work, blood is carried to the kidneys via the renal arteries, and then it leaves the kidney via the renal veins. So when possible, we like to mimic that natural flow in the body and have arterial blood, you dialyze arterial blood, because that is what goes to the kidney. Now, it's pretty hard to do arterial punctures over and over again, 3 times a week, for instance, for the patient. So we have to find ways to get good access to the arterial system. One way is to create a fistula. And so the physician may create a fistula between an artery and a nearby vein. So we have AV fistulas. For NCLEX, you don't have to know the difference between end to end, side to side. So that we create this fistula, and you now have a reservoir of arterial blood. If you look up at this arm up here, you can see a couple of fistulas. Now, this one would have been done first, the more distal one first, and then the more proximal one would have been a later one. Once you've done one, you can't do one distal to that. You've ruined the circulation for that. And when they have an AV fistula, then the line to the dialyzer goes in so you can get arterial blood, and then the return line will go in to the venous aspect. This is just another type of view of an AV fistula with an artery and a nearby vein that are joined together. Another way of doing it is something called an AV graft, arterial venous graft. Again, you can get a quick access to arterial blood to go to the dialyzer, and then the venous blood goes back into the system. Sometimes we can't use arterial blood, so we might use venous blood. This picture shows us a venous catheter that in the subclavian that might be used. We sometimes can also see femoral veins as well used as a source for blood for hemodialysis. In hemodialysis, the blood goes through the dialysis machine, gets filtered. All those things that we talked about that are the functions of the kidney happen in hemodialysis. And so the patient sits in a chair, much like you see in this picture, and the blood gets cleaned, if you will, in the dialyzing machine, and then goes back into the venous side of the patient. So that's what's going on with hemodialysis. Remember that hemodialysis is usually done 3 times a week. Takes about 4 hours or so for hemodialysis treatment. So the patient is undergoing hemodialysis half a day. Well, realistically, it takes him all day by the time he gets there, gets the treatment, gets home. So 3 days a week, the patient has to undergo hemodialysis. Now, for patients that are undergoing hemodialysis, Prior to the procedure, you ask them to empty their bladder. You will also weigh them because we're looking at weight changes during dialysis. Monitor their vital signs. What would you expect would happen to their blood pressure during dialysis? It should go down if they're getting rid of excess fluid. Observe for bleeding. Remember that the blood is heparinized as it goes through the dialysis machine. So if there was any bleeding and you've got heparinized blood, wow, you could have a massive bleed. Now, you would want to withhold any drug that was a vasodilator, like blood pressure medications, because the blood pressure will drop anyway during dialysis. Water-soluble drugs should be withheld as well, because they would be simply dialyzed out during the dialysis procedure. A fat-soluble drug like vitamin D could be given to the patient, but in point of fact, we usually withhold most drugs before hemodialysis. If you were working on a hemodialysis unit, you would have long lists of drugs, and you'd see the few that were safe and most that need to be withheld prior to dialysis. Let's do a question. Which observation indicates that hemodialysis has been effective? 1, a weight loss of 5 pounds. 2, polyuria. 3, an increased blood pressure. Or 4, glycosuria. The best answer is number 1, a weight loss of 5 pounds. So during dialysis, fluid is being lost and fluid weighs. So we would hope that the patient would have lost weight he should weigh less following dialysis than he did at the beginning of the treatment. And as we mentioned before, the blood pressure goes down. Dialysis does not make the patient urinate. It simply gets rid of the fluid via another method. We also need to look at peritoneal dialysis. In peritoneal dialysis, the dialyzing membrane is the peritoneum. Now, the major complication of peritoneal dialysis, as you can well imagine, is peritonitis, an infection. And the major symptom of that is a cloudy dialysate. Now, one of the pluses, if you will, of peritoneal dialysis is that they lose a little more protein during the procedure so that their diet allows them a little bit more protein, an extra piece of chicken, if you will, for this patient. There are a couple of kinds of peritoneal dialysis. We're going to look at 2 or 3 different variations on this. The first one I want us to look at is peritoneal dialysis that might be used for an acute renal failure. This could be done almost anywhere. In this, the physician makes a little stab wound in the abdomen. The dialysate goes in. It takes maybe 10 or 15 minutes to go in. It can dwell for half an hour or so, and then it can be emptied right out. And that's called an exchange. And they can do a number of different exchanges. I mean, they can do 24, 48, 72 exchanges perhaps. And this could be done anywhere, doesn't require a lot of special equipment, so it could be done for an acute renal failure, and is really designed for relatively short-term emergency kind of use. Now, there is something called a continuous ambulatory peritoneal dialysis, and in this situation, the physician implants a catheter that will stay in the peritoneal cavity. So they implant a catheter into the peritoneal cavity. And then, so let's follow the patient through the course of a day here. The patient gets up in the morning and drains out what was in there at night, then puts more dialysate in. Once it has flowed in, then they will cut it off and the patient will go about their activities. It's kind of slosh, they got fluid in their abdomen. And then at the end of 4 hours or so, usually 4 hours in the daytime, 6 or 8 hours at night, then they will empty it out and put more in and repeat the process all over again. So that's a continuous ambulatory peritoneal dialysis. It means that they are continually being dialyzed but they can be up and about. The only time they need to really sit down is when they're emptying it out and putting more in. This next picture just shows us someone doing the emptying out and putting in of their dialysis, of their dialysate with continuous ambulatory peritoneal dialysis. Now, this is another variation of that peritoneal dialysis. This uses the same setup with a catheter in the abdomen, except that this is done at nighttime. So this patient has a cycler that will let them do this at night. So it cycles in and out. So it's constantly moving back and forth, but this is done at night. So the patient could conceivably go to work and come home and then do their peritoneal dialysis during the evening and nighttime hours. Or if the patient was unable to take care of it themselves and they had a family member that would go to work and come home and set them up for it at night. So this allows a little bit more flexibility. Let's look at a question. The nurse is teaching an adult who is starting continuous ambulatory peritoneal dialysis. Which topic is of highest priority? 1, how the machine cleans the blood. 2, principles of diffusion. 3, aseptic techniques. Or 4, body image changes. And the best answer to this question is number 3, aseptic techniques. So we want to prevent infection in this patient. So aseptic techniques would be of highest priority. The patient really doesn't have to understand how to clean the blood, how the machine cleans the blood. They want to know it, that's nice, but they don't have to understand the chemistry of it. As long as they keep things clean, then they're not so likely to get peritonitis.